Chapter 25 here, bleeding and shock. So we're going to cover the circulatory system. We've covered it multiple times before, a little bit more in depth. A little review, bleeding and then shock, which we all know is hypoperfusion. The circulatory system. Here's a little diagram of the entire system, from the pulmonary circuit to the systemic circuit there, to where it's perfusing the organs of the body. Main components, you have the heart, just the pump of it all, the blood vessels, and the blood. Arteries carry oxygen-rich blood away from the heart, comprised of thick muscular walls that enable dilation and constriction, depending on what needs to be happening. Capillaries, microscopic blood vessels, vital exchange site. It's where the oxygen nutrients pass through capillaries walls in exchange for carbon dioxide from the cells. It's taken back into the blood and disposed of. Veins carry oxygen depleted blood rich in the carbon dioxide back to the heart. Contains one-way valves to prevent backflow of the blood. So the functions of the blood: transport of gases, the oxygen and carbon dioxide, carries nutrition, excretion, protection, and regulation. So perfusion is adequate circulation of blood throughout the body. It's oxygenating everything that it needs to. Hypoperfusion is inadequate perfusion of body's tissues and organs, not getting O2. So bleeding. Hemorrhage is severe bleeding. It's a major cause of shock, hypoperfusion, and trauma. It can be external or it can be internal bleeding. So external, arteries. If it's an artery, it's going to be spurting blood. It's going to have a pulsating flow, bright red in color. It can spurt out quite a distance. Veins, it's a steady flow, it's slower, and it's a dark red color. Capillaries are a slow, even flow. Okay, the only time that it could not be an artery, you're going to have like more of a bright red blood, is going to be spurting. Varicose veins, they can pop, and when that happens, it's bright red blood, and it's a steady flow though. It's not really spurting, but it's shooting. It can shoot quite the distance. It will look like a murder scene when you show up for those. So external bleeding occurs outside of the body after force penetrates skin and lacerates or destroys underlying blood vessels. Typically visible on the surface of the skin. How much they bleed is determined by a few factors: size and severity of the wound, size and pressure of ruptured vessel, the individual's ability to clot. Remember, a lot of things affect that: medications or diseases. Massive hemorrhage, arterial bleeding, bright red, spurting with each heartbeat. So every time your heart beats, you're going to get a spurt coming out. Very oxygen rich, which is part of the color. It's the most difficult to control. These are life-threatening bleeds. Venous bleeding is darker than the arterial. Still reddish, but it is darker. Less pressure. The volume of blood carried by some veins can create immediately life-threatening hemorrhage, sometimes with the varicose veins. Other external hemorrhage, capillary bleeding caused by superficial wounds to surface of skin. Slow oozing. Stops spontaneously once the clotting effect happens. You ever gotten a paper cut on your finger? It's going to bleed for a little bit. It's nothing major. That's your capillary bleeding. Bleeding can be accelerated by underlying conditions. Prescribed meds designed to limit the body's natural ability to form blood clots. These are your blood thinners. Patients that take a daily aspirin, same thing. Hypothermia affects body's ability to clot. So anytime you're out in the extreme cold, remember that's going to be affected. So think about it when you're on scene. How severe is the bleeding? Okay. Is it exacerbating hemorrhage? So how does that affect the priorities of treatment? You need to take a look. It's very easily to recognize a life-threatening bleed. You're going to have that spurting. You're also going to look at how much have they already bled out prior to my arrival. So use standard precautions. Gloves, as always. Depending on what's going on, you may want more protection. You're going to ensure an open airway, as always. Your ABCs, right? Adequate breathing. Control bleeding only after assessing and treating prior elements. Be aware of signs or symptoms of shock. Now, if you show up on scene and you see spurting blood, you're going to treat that immediately. You're going to put a gloved hand and you're going to put pressure on that wound. Direct pressure, elevation, hemostatic agent, or a tourniquet to control bleeding. Tourniquets are lifesavers. They kind of got away from tourniquets for a while. They believed it could cause more damage and may lose their leg. Finally, somebody wisened up and realized, yeah, they could lose their leg. You can cause tissue damage, but you're going to save their life. So tourniquets have made a return now. A lot of people are out there really advocating for tourniquets, a stop the bleed program, and it's hopefully tourniquets will be everywhere shortly. Direct pressure. Apply firm pressure to the wound with a gloved hand and a gauze bandage if readily available. If not, you're using a gloved hand. Hold pressure until bleeding is controlled. Just like that patient where his femoral graft blew. That's all I did the entire call. Held pressure. If necessary, add dressings when lower ones are saturated. Never take the dressings that you already have off. That can disrupt the clotting system. You just add more dressings to it. Once bleeding is controlled, bandage a dressing firmly in place to form a pressure dressing. Like I said before, never remove bandages, even when bleeding is controlled. When controlled, check for pulse distal to the wound to make sure dressing has not been applied too tightly. The pressure dressing, place several gauze pads on the wound. Hold dressing in place with self-adhering roller bandage. Wrap tightly over the dressing above and below the wound site. Create enough pressure to control bleeding. Elevate. Elevating an injured extremity above level of the heart while applying direct pressure. Do not elevate if musculoskeletal injury, impaled objects in extremity, or spine injury is suspected. Hemostatic agents. Designed to enhance direct pressure's ability to control the bleeding. Work by applying a material designed to absorb liquid portion of blood and leave larger form elements to clot. Originated as powders, but does not include dressings and gauze bandages. Manual pressure is always necessary. So these are your quick clots. This all started in the military, that's why it says combat gauze right there. I have used these quite a bit on major bleeds. They seem to work well. So tourniquet. Use of bleeding is uncontrollable by direct pressure. Use only on extremity injuries. Okay, always apply between the wound and the heart. Can't apply a tourniquet to the abdomen. You can't apply a tourniquet to the head or the neck. Should be common sense, but we will cover that. Here's a picture of a tourniquet. There's a lot of different ones out there. Know the ones that you're going to use on your service. Be very familiar with them. And another thing with tourniquets, a lot of times they will come in like this vacuum sealed package. Take them out. In a case of a life-threatening bleed, you don't want to take the time to open up a package to get to the tourniquet. They should be unpackaged, ready to use immediately. So follow the instructions by the manufacturer. Once applied, do not remove or loosen. Attach notation to patient alerting other providers tourniquet has been applied. You also want to note the time that it was applied. So is the current method of bleeding control working? Do you need to move on to a more aggressive step? How would you evaluate this? If I see spurting blood, it's going to be a tourniquet immediately. A lot of times We're going to try direct pressure, see if that works, and then if not, we move to a tourniquet. But you need to control the bleeds. The systematic approach to treat uncontrolled external hemorrhage. It's recommended by American College of Surgeons. Begins with direct pressure. If that doesn't work, a tourniquet. If ineffective in wound on trunk or head, apply hemostatic dressing or bandage with direct pressure. Splinting, stabilizing sharp ends of broken bones. And the reason for that, if left unstabilized, it can actually nick arteries and cause more bleeding. Inflatable air splints are a great tool if your service has them. Cold application. It minimizes swelling, constricts blood vessels, and reduces pain. It's used in conjunction with other manual techniques. Head injuries from increased intracranial pressure, not direct trauma to ears or nose. Stopping bleeding only increases intracranial pressure. Allow drainage to flow freely using gauze pad to collect it. Nosebleed is called epistaxis. Have patients sit and lean forward. You don't want them leaning back with their head tilted up. That will actually allow the blood to drain down the throat. That's not good. Lean forward. Apply direct pressure to fleshy portion of nostrils. Keep them calm and quiet. Don't let them lean back. If they become unconscious, place patient in recovery position. Be prepared to suction. There are actual nose clamps out there now that you can apply that helps keep the pressure on. Internal bleeding, a lot harder to recognize. Damage to internal organs and large blood vessels can result in loss of large quantity of blood, sometimes in a very short period. Blood loss commonly cannot be seen. You may see signs, but you can't, you're not going to see the blood. Severe blood loss can even result from injuries to extremities, especially the lower extremities. Mechanisms of blunt trauma that may cause internal bleeding, falls, even simple falls with the elderly. Okay, MVCs, motorcycle crashes, you have your high mechanism of injury, auto to pedestrian collisions, people hit by vehicles, and blast injuries. Penetrating trauma, you can have gunshot wounds, stab wounds, impaled objects. They will be bleeding externally a lot of the times, and they can have internal bleeding too they can't see. So the signs of it: injuries to surface of body, especially if it's high mechanism, you want to suspect it. Bruising, swelling, or pain over vital organs. Remember, the spleen bleeds a lot, so if they have pain on that side, there's been an injury, suspect internal bleeding. Painful, swollen, or deformed extremities, bleeding from the mouth, rectum, or vagina. Tender, rigid, or distended abdomen, vomiting coffee grounds-like substance, or bright red vomitus. Coffee grounds would be an internal bleed that's been going on for a while. Bright red would be something that's been acute. Dark tar stools or bright red in the stools. Again, that's going to be the same. The dark tar stools is been going on for a while. Then signs and symptoms of shock, hypoperfusion, their blood pressure is going up. So here you have patients in a night collar there. I'm guessing this is some type of car accident trauma there. You see the bruising there, okay? Typically you're not going to see bruising right away. And bruising is just blood underneath the skin. So if you're seeing that quickly, there's some type of internal bleed. So the care of these patients, maintain the ABCs as always. Administer O2 if needed by non-rebreather mask. Again, titrate to effect. May not always need a non-rebreather. Control any external bleeding. Take steps to preserve body temperature. Okay. We talked that cold packs can constrict the vessels and slow the bleeding, but you also want to be treating for shock. You want to keep the patient warm. Provide prompt transport to an appropriate medical facility. If it's a major trauma, you may want to bypass a medical facility for a level 2 or a level 1 trauma center. So shock hypoperfusion. It's inadequate tissue perfusion. Also causes inadequate removal of waste products from the cells. Failure of any component of circulatory system. Heart loses the ability to pump, either due to trauma or disease. Blood vessels dilate, making too large a container to fill. Blood loses volume from bleeding. Here's a little diagram of shock and showing the stages of it. So we have levels of shock, okay? We have compensated shock. The body senses the decrease in perfusion and it compensates naturally for it. These are the early signs of shock. They're going to be tachy, respiratory rate's going to go up, okay? Your body can do this for quite a while. Decompensated shock, because when the body can no longer compensate for low blood volume or lack of perfusion. This is a late sign of shock. Hypovolemic shock, decreased volume of circulating blood and plasma. Called a hemorrhagic shock if caused by uncontrolled bleeding, whether it's internal or external. Can be caused by burns or crush injuries or severe dehydration. Cardiogenic, seeing patients suffering an MI, damage to the heart. Inadequate pumping of the blood by the heart, decreasing the strength of contractions. The heart's electrical system may malfunction, causing a heartbeat that is too slow, too fast, or irregular. Now, just because the patient has a fast heart rate or a slow heart rate or irregular doesn't mean it's cardiogenic shock, okay? There's got to be more going on. You got to look for the other signs of it. Neurogenic shock, uncontrolled dilation of blood vessels because of nerve paralysis. There's no blood loss, but the vessels dilate so much that the blood can't keep up. There's not enough volume and you're going to become extremely hypotensive. This is rarely seen in the field. Now, peds are different. They're very efficient at compensating extremely well, okay? They maintain their blood pressure until half of the volume is depleted. Now think about that. They can lose half of their blood and still have a good blood pressure. Peds, kids, they will compensate for a very long time, but when they crash very quickly. They'll be incompensated, and there's really not a decompensated. It's compensating and then oh shit. Potential for shock must be recognized and treated before the telltale signs appear. If you're seeing signs of shock, it's a good possibility it's too late. So progression of the signs and symptoms of shock can be altered. Pale, cool, clammy skin, nausea and vomiting a lot of times. Their vital signs are going to change depending on where they're at. Okay. Late signs of shock include thirst, dilated pupils, cyanotic. Transportation is an intervention. It needs to be rapid. Every minute between the time of injury and the patient getting to an operating room is in fact like gold to the patient. This is where the golden hour comes in. That's why they call it that. Gold is platinum, 10 minutes at the scene. If you have, anytime you have a serious call, whether it's shock, cardiac, trauma, whatever, your on-scene time needs to be limited. 10 minutes or less is the goal. I've had on-scene times of less than 2 minutes. And I'm doing everything en route for the patient. If you can do that, great. Prevent heat loss, coagulopathy, and further blood loss. Okay. Treat the patient. Control the bleeding. Treat for shock. Maintain open airway and assess the respiratory rate. Address inadequate breathing immediately and aggressively. If they're breathing adequately, give them O2. Titrate to effect. Control any external bleeding. If a pelvic fracture is suspected, use a pelvic binding device if you have one available. Not all services have them. We do up at Genesis. I've never actually used one, but from those that I have talked to that have, they say it works very well. Splint any suspected bone or joint injuries. Prevent loss of body heat. Transport patient immediately, emergent. Speak calmly and reassure throughout assessment and care. Slide through this review here. Almost all external bleeding can be controlled by direct pressure and elevation. Those don't work, need a tourniquet. Utilize the hemostatic dressing if the bleeding is on the head or the torso, somewhere where you can't use a tourniquet. And a lot of times, even on the extremities, you can use one of those dressings and wrap it in place. You do a pressure dressing, it'll work just fine. Emergency care for internal bleeding is based on prevention and treatment of shock. Early signs: restlessness, anxiety, pale skin. They're going to be tacky, and they're going to be breathing rapidly. Blood pressure is normally either a little bit elevated or within norm. If shock is uncontrolled, the patient's blood pressure falls dramatically. That's a late sign of shock. Signs and symptoms may not be evident early in the call, so treatment based on the mechanism of injury can be the best thing for the patient. Treat shock by maintaining airway, apply O2, control any bleeding, keep the patient warm. One of the most important treatments is early recognition and immediate transport. Circulatory system is designed to ensure adequate perfusion of the body. Classification of hemorrhage is directly related to the type of vessel ruptured and the pressure within that vessel. Treatment of external hemorrhage includes progression through the following steps: direct pressure, elevation, tourniquet, hemostatic agents. Internal, it's impossible to evaluate. Rapid transport to an appropriate facility is best. Treat for shock. Shock develops if the heart fails, blood volume is lost, or blood vessels dilate. Anything affecting that perfusion, shock. Signs of shock reflect the body's attempts at compensating for inadequate perfusion, whether it's compensated shock or decompensated. Most significant treatment for the shock patient is early recognition and prompt transport. Can't say that enough. So what can I use for a tourniquet that will control bleeding but not damage tissue? Tourniquets are designed specifically to not damage the tissue. They're wider. They're not going to cause tissue damage such as possibly a belt and other things. When treating a patient with shock, what should I do at the scene and what should I do en route to the hospital? If they're in shock, as much as possible should be en route to the hospital. Only thing that should be done at scene is prevent further injury from getting them into the ambulance. That's it. Get them going. Is a patient with pale, cool skin, tacky, and rapid shallow respirations in shock or just under stress? Well, it depends on the call. And you're going to have to look at the events surrounding it. Okay. How will continuing assessment help in making that decision? You're going to constantly assess the patient. And just because it could be due to stress doesn't mean it won't turn into shock. The patient has been involved in a motor vehicle accident. There's considerable damage to the vehicle. Steering column and wheel are badly deformed. Now think about that. If that's deformed, there's been definite blunt trauma to the chest. The patient complains of a sore chest. No external bleeding. Patient's vital signs are a pulse 116, respirations 20, blood pressure 106/70. How would you proceed to assess and care for this patient? So they're tacky right now, respirations are within norm, their blood pressure is a little low. I have a high suspicion of internal injuries, internal bleeding, because of the mechanism of injury and the damage to the vehicle. I would treat this patient for shock, and it would be a load and go transport immediately to a hospital.